Good morning, everyone, or good night, whenever you're listening to this. So this is going to be on GI drugs, and let me screen share. Okay. All right. So we're going to go over the gastrointestinal system. I'll minimize this so I can see. Thanks. Okay. We're going to review a little bit of the material that we talked about. Then we're going to get into the GI drugs, and that's it. Okay. So review. So remember the upper respiratory tract, the ones we're concerned about are decongestants and drugs for allergic rhinitis. So decongestants, which help with the sneezing and rhinorrhea that you get, are sympathomimetics. So they're alpha 1 adrenergic agonist, and essentially they're like ephedra that your body makes itself. It works on nasal congestion primarily. So it's only going to work when the drug is in your system. They have a relatively short half-life, which is why you have to take them every day. When they're done, sorry, I got my chime in the background. Hopefully that isn't bugging you. When they're done, then you're going to have rebound effects. So like the congestion's still going to come back. You could, while you're on it, have some cardiovascular effect because epinephrine speeds the heart up. Okay. And this is really more for symptoms. So you're looking at the symptoms of a cold or the symptoms of rhinorrhea, um, of chronic allergies. So they're going to have to take it for the entirety of the season, which is why it's good to use like an herb or something that's different. Um, but just know that if somebody is doing this, like say they have a cold, then it's actually preventing the immune system from working. So they're actually going to be sick longer. Okay. It is an over-the-counter drug, which means you can get Pseudoephedra without a prescription. It does require an ID because they do track how much Pseudoephedra you can get because the abuse of it is they can make meth out of it, and so you're not allowed to buy large quantities. Okay, you have the glucocorticoids that are intranasal, and then you have the antihistamines that are oral and intranasal. Okay. Your first drug of treatment is intranasal glucocorticoids because they're going right into the nasal cavity. The problem is they can dry out the throat, and they do dry out the nasal mucus because the point is to decrease that. They can cause nose bleeding. They can cause headaches again. And the rare side effect is adrenal suppression. But you'll mostly see this in like peds, or someone who's like really overdosing on this drug. It's not usually a huge concern with this. Over long-term use, you will see some change in the nasal mucosa if they continue. The oral antihistamines, they don't reduce, remember, they don't reduce the nasal congestion. So they're only going to work on the inflammatory aspects of this disease. So they're taken prophylactically, so they're taken as needed. You can do it regularly. Most people do it regularly to prevent histamine from building up. So they'll take it, there's 24 hours, there's 12 hours, and they'll take it every so often. Remember, the second generation is less sedating. The first generation is more sedating because it crosses the blood-brain barrier. Oh, sorry. And because of that, those antihistamines like Benadryl are used more in sleep aids nowadays and less for allergies unless it's severe. So, like if you're doing an anaphylaxis or you're having a hives reaction, then you're most likely going to use Benadryl because it has a better antihistamine response for blocking the histamine receptors, but it also has a bigger sedating response. Okay. And your mechanism is you're preventing histamine by binding to the receptors and preventing the release of it. So again, your first generation is like the Benadryl. That's also used in a lot of your sleep aids. And then your second generation is Zyrtec or Allegra. These less likely to cross the blood-brain barrier, so they end up having less side effects. All right, now we'll talk about GI drugs. So the most often used for GI drugs, we'll talk about that and how to determine if they're safe and go from there. So this is a book that if you want to go and explore the GI tract and what it all does, please feel free. It's kind of graphic in the fact anatomy and stuff. So just know that going into it, but it's a good book to go through the digestive tract. Okay. So here's the digestive tract. You have the oral cavity, you have your salivary glands, your pharynx that goes down to the esophagus, it enters the stomach, goes into the duodenum, the large intestine, um, right past the stomach, you've got the liver that empties into the gallbladder as a storing agent, goes through the common bile duct along with the pancreatic juices, breaks down the food, and then you go into the large intestine and out the rectum. Okay. When we look at this, remember that if we slow down the GI tract, right? So we want to decrease its movement. We're going to increase the bioavailability of whatever drug or herb we gave them. Just know that. And then if you increase the gut mobility, you're going to decrease the bioavailability of whatever drug they're taking or herb. So remember that because we're going to talk about constipation and diarrhea, and each one of those is either slowing the GI tract down or speeding it up. Okay. Also, we begin eating with our eyes and with our nose. So as soon as like you smell food, sometimes if you think about it, if you see it, you start the salivary glands going, you start the stomach acid production, your pancreas starts to produce some enzymes. So you really get primed and ready to go for food. So the first ones we will talk about today are peptic ulcer disease and gastric reflux disease, which GERD or PUD. There is also duodenal ulcer disease. They kind of go hand in hand with peptic ulcer disease. The difference is that peptic ulcers in the stomach and duodenal ulcers just past the stomach. So one actually ends up hurting the patient when they are having food in their system, and one actually feels better when they have food in their system. So that's an easy way to tell which one they have. And then we'll go into constipation, diarrhea, and a little bit of nausea and vomiting. Okay. So with peptic, so with the gastric secretions, remember you've got your parietal cells. Your brain starts thinking about food. It releases ACTH, which goes activates your parietal cells, and it goes down, also activates your ECL cells, and then activates your G cells and secretion that activate the gastrin that go back, and then also activate the histamine. Okay, so these are all working, and they're all working in slightly different ways. So your acetylcholine, your histamine, and your gastrin are all working to produce acid secretion. There's some YouTube videos down here. My favorite YouTube video for like Western stuff is Osmosis. It goes through some nice um, different ones. Oh, you can see if I can put it in the chat later or next time. But if you really want to learn like Western diseases in a nice little short YouTube channel, Osmosis is really great for that. So in peptic ulcer disease, what we're trying to do is peptic ulcer disease. Hold on, I'll get that in a second. So here's another one about the parietal cells and how they work. So the histamine, the prostaglandins, The ACH all go in, and then you're activating kind of the mucous membranes for the stomach lumen. Okay, so this is just a nice biochemistry reaction. So, in a healthy gut, in a healthy stomach, sorry, you're producing mucus, and that's the outer coating of the stomach so that the stomach acid doesn't eat the cell lining. And then you're also producing bicarbonate, okay? The blood flow to the cells also prevent and are healthy. You don't want to increase too much blood flow because then you're going to have problems with your cells producing mucus and producing other things that it needs. And then also prostaglandins. So the prostaglandins help produce the mucus, which is super important because your remember your stomach acid is really low. It's like I think it's at a 2, and so it needs to be that low to break up the food content that you just ate. However, it also can degrade your cells. So if it gets out, it gets anywhere else, it starts degrading stuff, which you don't want to have happen. And when you have ulcers, that mucus protection is no longer there in some places, and it's starting to eat away at your cells. And some factors that cause this are H. pylori. So this is a gram-negative bacteria that can cause it. NSAIDs, which we talked about, that block prostaglandin productions, especially in the stomach. It will cause an ulcer. Acid, so too much acid can cause this. So if you're overproduction of acid, and pepsin and smoking. So all those factors. So here's what it looks like. So you're supposed to have this mucus layer right on top, and then you have some of your mucosa, right, that are producing. Those are where all your cells are, your parietal cells, all that stuff that's nicely producing all this enzymes to go into the stomach. Then you have your your next layer, and then you have your submucosa, right? So with increased damage, you take increased NSAIDs, you keep drinking alcohol, cigarettes, whatever you're doing. Um, it starts damaging that mucosa layer, the mucus layer, and gets down into the mucosa. And that's where it starts to degrade faster. And what happens is you get all the way down to the submucosa and you cause necrosing of the tissues, and then there'll be bleeding that happens. And so then you'll have um, a bleeding ulcer. Okay, and that's what we call it. And it'll come out in the stool, and it'll be kind of like coffee grounds because it's been in the body for a long period of time. So the blood's kind of old, and it'll look like little coffee grounds. Okay. So the most common cause of peptic ulcers is H. pylori. However, it is not the only factor. So, key fact, when the population reaches 50 years old, 50% of the population has H. pylori in their stomach, but 50% of the population doesn't have peptic ulcer disease. So it is a factor, but it is not the only cause. So it doesn't mean just because you have H. pylori, you're gonna have a peptic ulcer, but most of the time when they find a peptic ulcer, you will find H. pylori. Okay. But see, it says only 10% develop into peptic ulcer disease. So it really kind of counts on other factors. And then H. pylori infection is also linked to gastric cancer. But again, if it's a direct link, we would see a lot more gastric cancer than we do, and we don't. So that is something to also consider. NSAIDs are direct linked. Sometimes it matters what brand. So if they're on Motrin, and they get sort of that feeling, the GI feeling, and they're not feeling so good, and they get some stomach pains, you can switch them to a different NSAID, and they might be fine. I'm not sure why the brand makes a difference, but in NSAID's case, you can switch brands, and they might be perfectly fine. I would take them off it completely, but there's that. And then hypersecretion of acid in the stomach. So that's overproduction of acid in the gastric lumen will cause peptic ulcers just because you're producing way too much. Now that's usually mostly a genetic thing, and is not as prevalent as people would like to think. So the non-drug therapy is diet. So they have you decrease caffeine products, decrease alcohol, reduce your stress. They have you eat small meals a day, like 5 to 6. They have you stop before dinner time. They make sure you eat 2 hours before you go to sleep, which is actually a good thing. So if you have like smaller meals, your body's able to digest. It reduces the amount of pH fluctuation. So the larger meals will really make your stomach more basic faster, and then you have to produce more stomach acid to break it down. So having that smaller meal means you don't bring up the stomach to such a basic level. You don't have to produce as much acid, and so it's a little bit better to have that throughout the day. Uh, not eating 2 to 3 hours before bedtime is great because if you eat right before bedtime, especially if you have a heavy meal and then you go lay down, now your body is in an upright position and it can inhibit the ability of the body to excrete food, and it can go up. And actually, that's where a lot of gastric reflux comes from. Um, is sometimes those really heavy meals where you're producing a lot of acid and then you're going to bed and you just keep doing that over and over and over again. And the acid ends up going up into the esophagus, and that's where you get the GERD, the acid reflux, because the acid is going into the esophagus. The esophagus doesn't have any mucus lining in it. You get the burning because the cells are dying from the acid in the stomach, eating it out. And it's a really unpleasant feeling. And you can actually change your esophageal cells at the bottom. You just lose that and over time. And so it's not really a great thing. You want to avoid smoking and said alcohol. And then the biggest thing, and especially with what you guys are going to treat, is reducing stress. So, as you know, as you saw, that you know, it's mostly caused by H. pylori, but if that was the case, then 50% of the population at age 50 would have gastric ulcers, I mean, peptic ulcers, which they don't. So there has to be some sort of environmental genetic factor. And one of the big things is stress. People stress themselves into ulcers. So there's no amount, if they continue the same stressful life, you're just going to put a band-aid on it, just like Western medicine. So you really want to work with the person to reduce their stress, whether that's journaling, I personally like yoga or taking runs or hiking or maybe looking for other jobs, looking for a coach to help them work with their job better, their housing situation. I mean, all the things that we stress about. If there's ways to help them with that, or avenues to help fill up their bucket, so when they're in that stressful job, it takes away, it doesn't drain them as much. All good things to help them with, especially with this disease. Okay. So the drugs to treat PUD and GERD, we don't usually use antibiotics in GERD, but you use some of the other ones. So you're using histamine 2 receptor agonist, and then protein pump inhibitors and antacids. And antibiotics are the only ones that are targeting the H. pylori. You're only on the antibiotics for a short period of time, like 10 days, but you could actually cycle through antibiotics. So you can be on a 10 days, take a couple day break or something like that. And then you can go back on another round of antibiotics. The other ones, you are usually on them for quite a long period of time. We're talking like 3 months, just to kind of help the GI tract heal. Okay. The stomach heals, the GI and the stomach tract heals faster than other places, but it still does take a while to help to do that. So the first one we're going to talk about is the H2 receptors. And what those are going to do is those are hopefully going to decrease the histamine from activating the cell and thus producing acid. Okay. So you're working on histamine receptor right there. And then the other place, the protein pump inhibitors, you're working on the actual ATPase, this protein pump right there to decrease how much acid is put out. Okay. So your H2 antagonists, so the H2 blockers are your first drug of choice because they help decrease the production of acid. Okay, so the whole point is to sort of make the stomach more basic, thus helping decrease the erosion of the mucus and the mucosa membrane so that it can heal. Okay. The problem is that you also now have a problem with digestion, right? If you get rid of your acid, then you're not going to be able to like digest the amount of foods. And so you do long term with these things, I mean, super long term, especially people with GERD and stuff, will have some nutrient depletion and problems that way because you're not getting in the same amount of nutrients because you're not breaking down your food as much. And so therefore you can't absorb it the same way. So really think about that for long-term people who are using this. If they're just having a gastric ulcer and they just use it for, 6 months, yes, they're going to have a problem, but it takes a little bit longer to do vitamin deficiencies over a long period of time. So they're not really going to see some deficiencies. They'll be fine. You'll put them back on track afterwards. Um, but this is so what you're trying to do here is like your stomach is a pH 2. I'm trying to bring it up. So you're trying to bring it up to like 4. Um, so there are some serious side effects, but they're uncommon. So this is for really long-term use. You can have gynecomastia, impotence, and galactorrhea. Okay, long-term, or if there's on a super high dose for a long period of time. Clementine also inhibits several CYP450 enzymes. So it increases the chances of pharmacokinetic reactions related to metabolism. So if we're inhibiting the enzymes that make CYP450 work, that means we're slowing down the process and thus we're making whatever drug that they're taking more bioavailable, right? Say, or herb. So just think about that when you're doing that. So they work to block the H2 receptors and the parietal cells, thus suppressing acid secretion. Okay, so that's how they work right there. And then you're going to use it in gastric or duodenal ulcers. Okay. They also use it in GERD because GERD is, again, an overproduction of stomach acid or hypersecretion states. Okay. Heartburn is about the same as GERD. Okay. So is acid indigestion or sour stomach, whatever you want to call it. Okay. Um, Sorry, my dog wants to get up here. Absorption, if taken with meals, is decreased as an antacid. Um, it has a difficult crossing the blood-brain barrier, and so that's good because then that means you'll have less side effects. Okay. It's also why it's somewhat safe in pregnancy because we're not crossing anything. Okay, so these are really bad adverse side effects, but you're not going to see them that often. So you can have some, because they do cross the blood-brain barrier a little bit, you can have some CNS effects. We talked about the adrenergic effect, and then you can actually get some pneumonia by just decreasing um, the overall body's ability to deal with things. Okay. Uh, all right, so we talked about in inhibiting the CYP450, which raises the effective dose of the drugs, okay? It will also raise the effective dose of your herbs. If you want to, I would look at this video. It has a nice thing of how the protein pump inhibitors work. So you can see how those work in the cell. Okay. Protein pump inhibitors affect the gastric acid secretion. Okay, so they're inhibiting the gastric secretion. They have a short half-life. These things are over the counter and they're well tolerated. They're used for short-term use, but people use these long-term, which is why you can see increased fracture rates and stuff because you have um, the the absorption problems with nutrients and food long term. Okay. But it does help with the symptoms that are happening right away. Okay. It can also, because it's changing your stomach acid and the pH, it can cause some risk of like C. difficile because it's an opportunistic infection. Because when you change the pH of the stomach, you're kind of changing the pH for your rest of your GI tract, which can have opportunistic bacteria pop up. Okay. So you want to be careful with that. It also has a nasty rebound side effect. So if people just stop their PPIs that they've been on for a long period of time, the stomach is very well adapted to producing acid and will increase the acid production exponentially, and thus causing some very painful rebound GERD. It's not going to kill them. It just is not pleasant. So what you want to do is you actually want to stair step down, decreasing the PPIs and maybe increasing an herbal supplement in the meantime to help mitigate some of that, and also doing some lifestyle changes. My favorite one is DGL, which is a deglycerinated licorice. It doesn't have that cortisone sparing effect, but it acts sort of like a PPI. And so I slowly wean people off of the PPIs by giving them that. And you help prevent like this huge rebound effect that happens. Um, so you have omeprazole is the most common one you're gonna see, but the adverse effects are minor. They might have some headaches, some GI effects. The major ones that will only be if they're really, really long term is pneumonia, fractures, and hypomagnesiumism, and gastric cancer and C. diff, and that's just because of long-term use and long-term change of the pH in the GI system and the absorptions of things. Um, Antacids, you take these to like neutralize the acid that's already produced. Okay, so you're not going to decrease how much acid is in the system for the most part. All but one of them actually does, but most of them neutralize the acid that's in the stomach already. So if you're doing that, then you're helping decrease the destruction of the gut wall. Okay. Here are your antacid families. You have the milk of magnesium, you have your Tums, which is the most common one, your aluminum compounds, and then actually baking soda is an antacid, and it works very well. Tums is the most common, and Tums, actually, if you eat enough Tums over enough period of time, or you're popping these like candy, you can actually become hyperkalemic, which is a problem for your heart, along with some other things. But you can have hyperkalemia as a side effect of that. Um, sodium bicarb is really good. It will also cause some problems with your sodium levels. Okay. You can have, for milk of magnesium, magnesium is a osmotic diuretic, so it will cause diarrhea. And then the other two, Tums and aluminum, will cause some constipation. They do interact with the other drugs that are happening, so you want to take them separately. Also, there's no systemic effect on the pH because remember they're working directly on the stomach acid in the stomach, except for sodium bicarbonate because you actually absorb some of that and it will cause some pH issues there. And then you also want to be cautious in renal impairment. If someone's renal insufficient, you need to be careful about all sorts of things that they're taking and also eating. Like a high protein diet will cause some renal issues. So you So with renal impairment, you really need to be careful with herbs, drugs, or nutrition. That's important because remember, that's your elimination organ. So that's getting things out. All these drugs decreased gastric acidity, so therefore they're all going to inhibit or interfere with the breakdown of your herb and absorption of stuff. Okay, so you want to give, you want to remember that. So you want to give more bioavailable things so your body doesn't have to break down as much in the stomach. Same with like food, right? If I want to give patients easily more digestible food, things like cooked vegetables, not raw vegetables, because that takes another step to break down. Easily digestible proteins, not harder things. So remember that when your patients are on this. And then your herbal breakdown, think about the pills versus doing teas, because the pills have to be broken down. So you really have to think about all of these things. Okay, next we're going to talk about constipation. So constipation is a side effect for a lot of drugs. It's also the side effect of the American diet. So you have your bulk laxatives, you have your stimulant laxatives, osmotics, stool softeners, and chloride channel activators. And you have herbs that act in kind of all these same ways. Um, and these are just the drugs. So the weakest is stool softeners, and the strongest is chloride channel activator, which is the only prescription. The rest of these are actually over the counter, so you can get bulk laxatives like psyllium husk, which is Metamucil, osmotic, which is Miralax, and then you have your stimulant laxatives, which is your sienna, aloe, castor oil, those types of things. I would not use castor oil as a laxative, but aloe and sienna are a little bit better. Okay. So your stool softeners are your wetting agents. So what they do is they put water and they put fats into your stool to help you bulk it up and then kind of soften it to get it out. These are going to take a while, so they're not fast acting. So there's someone who maybe be constipated like every other day. They're something that's going to take a while to get into your system and start working. So if somebody is really like really constipated and backed up and in pain, that's not one you want to start with, right? You want to start with something that's going to help them a little bit better faster. Bulk agents, laxatives, those are absorbents, so they're going to draw some water into it so that the stool can have some more water and therefore be able to pass. Osmotic is going to draw salts and water into the intestinal lumen. And those you have to worry a little bit about dehydration. Okay, stimulant laxatives, those increase by causing the peristalsis. So they irritate the muscles to cause them to cramp and then they go out. That's especially how castor oil works, which is why you don't want to use it that much. And then the chloride channel activators work on the chloride channel agonists and cause like a super osmotic kind of diarrhea situation here. Okay, so with all of these, you do have herbs that work in all the same ways. So use your herbs first, but they're all going to have the kind of the same side effects. You are increasing the GI tract for getting the constipation out. And believe me, it's not fun and comfortable, but either is. So if you give too much too fast, you will cause significant cramping, especially with the osmotic and the stimulant laxatives, and that can feel like severe pain. Okay. You also want to be careful by giving too much because if the person is not near a bathroom, sometimes you stimulate it and there's no going back. So make sure this person has enough time and is available. And also make sure that It does take sometimes, even the osmotic and stimulant laxatives, they take sometimes 6 to 8 hours to take into effect. So that's something to also consider. There's also like traveler's diarrhea or traveler's constipation. That what I would use more for like a stool softener or a bulk laxatives and help them that way than necessarily like an osmotic or a stimulant. Okay. But if you're using the osmotic and stimulant, make sure the person has enough water in their system because you can dehydrate them. Okay, so our one laxatives, lupoprostone, is the only RX one. It's mostly used in chronic constipation, so someone who's on long-term opioids or IBS, right? That goes from constipation to diarrhea. It's mostly approved in females only for IBS, probably just because they did all the studies in that. But they'll probably use it off-label for males. It causes headaches and nausea, of course, because you're messing with the GI tract and you're messing with some of the arterial pressure and stuff. You'd never want to give any of these or this to somebody who has bowel obstruction. If somebody has bowel obstruction, they need to go to the hospital. Their bowel is not working. And if it bursts, it can cause all sorts of problems because you get fecal matter into the peritoneum, which can cause a massive infection and have horrendous side effects. So if you consider somebody has a bowel obstruction, they need to go to the ER. Um, so methadone may diminish the effects of this drug, so you don't want to take that. Usually you don't give it in the same thing. And there is no generic available. So this is like $7.42 a piece for this. So it is not a cheap drug, okay? And that's in the United States. So it's not something that you'll see very often just because there's so many other over-the-counter agents that they can use. This is usually for, again, severe cases where nothing seems to be working. All laxatives should be taken as directed. They all cause bloating, cramping, and gas. Okay, it just depends on the person of how bad these are going to be. It's not going to kill them. It's not going to last long. But essentially, they're all going to get uncomfortable. Constipation's uncomfortable as itself. It's just going to make it worse. Um, they're going to cause dehydration. And depending on how much they use, they're going to get severe electrolyte imbalance. So you want to make up for that. And then if they use it too often, you do get dependent on it, and your rectum and the peristalsis in your large intestine won't work as well. So you want to make sure that you are advising your patients not to be on these. And this also works for herbs as well. If you're using the stimulant laxatives or the osmotic laxatives a lot to produce to get rid of constipation, then they will get dependent on those as well. So it's not just the Western stuff. Okay. If you're doing some bulk agents, those don't have kind of the dependence on them that the other problems do. Or if they eat a bunch of fiber, that won't have it either. But you can get dependent on that. Caffeine is also a laxative. Okay, so people who drink coffee, that'll cause some stools to happen. And then the other one, the more extreme ones, we have those is you can get enemas or colonics. Enemas will be that's what they use in the ER hospitals to help. And so they put a tube up the rectum and then they give water into the area, hopefully to stimulate the bowel to happen. Sometimes they have to do this more than once. Um, they do not put coffee in it, but it is another way that they deal with constipation or somebody who is what they call impacted, which means most of their colon has stool in it. Okay, and you can store 5 to 10 pounds of stool in your colon. It's quite efficient that way. Colonics are you can go to colonic places. Same thing. They stick a tube up there in the rectum, and they push in water, and essentially help move out stool. You need to be careful because some people can have rebound diarrhea from that, and you can get dependent on enemas or colonics, so you don't want to do them that often. They're used as in alternative worlds as a detox agent, but you still don't want to do them long-term use. Okay? So that's what we have for constipation. And then for diarrhea, I forgot for the peptic ulcer disease, I told the other class like what I use for naturopathic version. It's sort of the same principles. I use a antimicrobial herbs. I like garlic and a couple other that I put together. Use that instead of an antibiotic. I use some mucus protection for the GI tract, and that can come from like slippery elm or some marshmallow root. It's really a demulcent that causes that sliminess and helps it create a mucus protection for the stomach. I use the DGL, which I talked about, for like a PPI. I also sometimes give digestive enzymes because those help the GI to digest the food down so you don't have to produce as much stomach acid sometimes. And then the other one, I do a lot of diet with the people, and then I give a supplement called GI Revive that has some nice vitamins and nutrients that really help the GI tract turn over in their cells, and that's a little more gentler approach and really helps build up the system. But you're still on it for three to 6 months to build that up. Okay. All right. Diarrhea. We only have two agents for diarrhea. They're both over the counter. We have Pepto-Bismol and anti-motility agents. Okay. Um, so okay. The big thing about diarrhea is most of the time we don't want to stop it. So you're getting diarrhea because you have food poisoning or you have some bug that attacked, and you really don't want to stop the diarrhea because essentially the diarrhea is getting out the particles of viruses or bacteria or toxins. And if you stop that, that means it's going to stay in your system and you're going to absorb it. And you don't want to absorb it. You actually want to get those things out of your system. If diarrhea becomes unproductive, so after so many days, it's watery, it's just the person's just really tired, lethargic, and you've seen that it's passed, then you can give some antidiarrheals. But most of the time, with those types of things, I don't want to stop it. The instance, which is also why we don't have that many, right? Um, the other time that you might want to stop it is if it's like chemotherapeutic, when they're going through chemo, can cause diarrhea. And that's just more about the drug causing it than it's actually toxins or anything you're getting out. So you can stop that. So that might be an instance where you would actually use this. And I have used it in patients with that. But everything else, I most likely just let it run its course. Okay. And then the last one is nausea and vomiting. Okay. So nausea and vomiting actually become are centralized in your brain. And so all of these drugs that they're going to use actually cross the blood-brain barrier, and that's important in a second. But essentially, it works in a couple different ways. You also have your vestibular nuclei that are in your ear, so your inner ear that kind of helps with balance and stuff. That goes into your spinal cord, and that one will tell your brain that it's off and will cause some nausea. And that's how sometimes have motion sicknesses, sometimes it's in the ear, sometimes it's also in the eyes. So the eyes looking at the horizon line, if it's unstable for people, will cause a reflex in the brain and cause you to be nauseous, which is why there's a couple different things like the eyeglasses that kind of help move the horizon line for you so that's not doing that. Because it works in the brainstem right there, um, and it crosses the blood-brain barrier, is the reason why there's like no anti-nausea drugs for pregnancy because it's it can cross and go into the placenta. So there's really no drugs that work, which is why acupuncture is great. You know, PC6, putting some of those patches on. Also, ginger, they just don't have the capability because these all these drugs go into the brain. So they all have like um, pregnancy categories that are not good for pregnant. Okay. Since they all cross the blood-brain barrier, they're also going to all cause any nausea, anti-nausea, anti-vomiting drugs are all going to cause sleepiness and drowsiness. So that's why Dramamine kind of puts you out because it's working on the brain and then it makes your brain sleepy and then you go to sleep. So you also want to be careful of that. So we have a couple different receptors that they're working on. Um, Scopolamine works in the vestibular into the sorry, and the spinal in the brainstem down here. Then we have some other different drugs and their different receptors that are targeting different parts of essentially the CNS spinal cord and the spinal and the tracts within the spinal cord, which is where they're working. Okay. They work mostly on 5-HT3 receptor antagonists. So they all have the potential, they're all very potent antiemetics. So they all will work very useful, especially in chemotherapy, therapeutic induced nausea and vomiting. However, they don't always work. They are all going to cross the blood-brain barrier, so you have to be careful. Um, they're they're located that the in the central nervous system that triggers nausea, the pathway, which goes up the spinal cord and then centralizes, um, and they block the neural impulse, okay, to prevent the nausea signaling from happening in the brain, which is why they cause dizziness and they can cause constipation. Okay, Zofran is your example of what you'll see most often. Um, but Dramamine works in kind of works the same area. It's just not as strong, and it works more on another part of the an upper part of the brain. Okay. This see these birth defects in the kids' hands and stuff. This is from one of the drugs that they use to treat pregnancy and nausea, which is why they don't use it anymore. Okay. There's too many. The side effects are devastating, so they don't really have anything for pregnancy, which is where you all come in. Okay. All right, I'm gonna stop screen share. Again, that's all the GI we have for today. So if you have any questions, please email me. Please go through these and just look at them. And again, you're changing the gut mobility and you're kind of sometimes speeding it up or slowing it down. And remember, that's gonna change how your herbs are also interacting and being absorbed. So take that all into consideration. All right. Have a good day, guys.